welcome everyone to our weekly webinar series, The Medical and Public Health Considerations of COVID-19. Today's webinar will be on mitigating the intersection of COVID-19 and opioid use disorder. Next slide. I'd like to thank our webinar series partners. Next slide. All these webinars are recorded and are posted to the ACMT website within about 48 hours or so. Our resources can be found on the ACMT website at acmt.covid/COVID-19 web. And any questions about the webinar series can be directed to info@acmt.net. Next slide. There will be a Q&A at the end of the webinar. We usually have quite a few questions. Feel free to type in your questions during the webinar, either into the Q&A function or the chat function on the WebEx link, or under the chat function with the YouTube, Facebook link. Next slide. And there are no conflicts of interest of any of the speakers. Next slide. I'd like to turn it over to our guest moderator for the session today. Dr. Lewis Nelson is the chair of the Department of Emergency Medicine at Rutgers, New Jersey Medical School in Newark, New Jersey. He's board certified in emergency medicine, medical toxicology, and addiction medicine. And he's brought together a wonderful panel for today's session. Thank you, Lewis.
Thank you, Paul. I appreciate the introduction, and I'm very happy that ACMT gave us the opportunity to talk about this really important issue that many of us are facing today. You know, my clinical practice is in emergency medicine. And for those of you that have followed the news or work in emergency departments, you recognize the important impact that COVID and substance use have played on the practice of emergency medicine. So we put together a group of panelists today who we'll introduce in just a moment. But I think we've done a nice job pulling together people from a whole different group of perspectives. I want to thank Dr. Jeanne Marie to really co-organize this conference with me, and together we were able to get this group who I will go through in a moment exactly how we're going to approach the day, but we've been able to put together a panel that's going to really address policy issues as well as some of the clinical issues that we're facing in the practice of addiction medicine as it's being practiced now under the current pandemic that we're all facing. The panelists that you see here are going to individually give a small introduction to the work that they're currently doing and some of the issues that they're facing in their own practices. And then we're going to get together after a few minutes of their individual discussion to ask the panel a group of questions, which should last about, I'd say, 25 to 30 minutes. And then we'll use the remaining time to open up to a Q&A for the audience to text in questions and to chat in questions. You've already heard that you can enter questions in the Q&A or the chat, or ask them on either YouTube or link or Facebook. And we'll try to address as many of those as we can. Obviously, we're not going to get through every question, but we'll keep the rest of the questions aside and try to get them posted on the ACMT website. So with no further ado, I want to thank the panelists for taking the time to share their expertise and insights with us. And I want to thank the audience for participating, hopefully in the Q&A session, and certainly for participating in the presentations that the panelists all have. So, Kimberly, if you could introduce yourselves and let me know when you want me to move to the next slide.
Thank you so much. Hi, everyone. My name is Dr. Kimberly Suh. I'm the medical director of the Harm Reduction Coalition in New York City. So I'm an internal medicine doctor by training, and I also do addiction care. So let's go to the next slide. So, I'd like to think about COVID and opioid use disorder with a case. So, as you all know, New York City has been the epicenter for the COVID pandemic, and there were many attempts to try to treat this, and one of them was decarceration. So I see patients in one of the syringe service programs in New York City regularly every Monday. And I got a phone call from someone who staffs one of those programs about this patient. So starting with this case, a 55-year-old male with hypertension, diabetes, obesity, anxiety, and depression comes to this syringe service program in New York City. He's just been released from prison 2 days ago in a decarceration policy effort. Reportedly, he has a history of opioid use disorder, doing intranasal heroin 5 to 6 bags a day, on and off for 10 years. And now he's homeless. He was discharged without a place to go. Previously, he'd been on methadone in the past, 80 milligrams, but he hasn't been on it during prison. He went upstate for about 2-year sentence. So importantly, the patient's at a very high risk of an opioid overdose, as he is now opioid naive. He also smokes cigarettes, and he's having cravings for heroin. And the program worker for the syringe service exchange calls me and says, is he a candidate for buprenorphine? Can you take me to the next slide? So this patient has a lot of features that make him very high risk for both an opioid overdose as well as doing poorly with the acquisition of COVID-19. This is a study that was based on some of the data out of China that emerged in the Lancet. So this patient is male, he's in his 50s, he's a current smoker, he has multiple comorbidities, metabolic syndrome, hypertension, diabetes, as well as being African American. And all of those put him at very high risk of doing poorly if he does acquire COVID. Next slide. So we're thinking about this patient from a lot of different angles of risks. Generally, this patient is already at very high risk of he's leaving prison or jail, which is a very tumultuous time. So we do know that people in that first 2-week period upon release from prison and jail are at very high risk of increased mortality and a very high risk of mortality from a death from overdose. We know that it could be 12 times higher of general risk of death, including heart attacks or violence, and overdoses is much, much higher. So I'm worried about him for a lot of reasons. And we also think that having these chronic medical and mental health conditions could be risk factors for acquiring COVID and doing poorly. Also, a lot of people leaving prison and jail might be returning to or sheltering in subways or in congregate shelter, homeless shelters, and they face a lot of risks there, both risks that they cannot practice physical distancing, risk of violence, assault, and overdose. We know that I'm concerned that he might have lack of access to harm reduction supplies, including syringes, naloxone, test strips for fentanyl, and really not being able to have people keep an eye on each other. We often tell people to don't use alone, and COVID has changed that. There have also been concerns about the drug supply and having an uncertain drug supply with people really, not knowing what they're getting. Again, there are also concerns about racism, stigma, and distrust of patients who use drugs within the formal healthcare system. And there have been some early suggestions that Blacks and Latinx populations are at a much higher risk of death. So I'll take you to the next slide. So the case continues. So basically, you could think about this as pre-COVID and during COVID, and the DEA is going to talk a little bit about a lot of how these changes happened. But there was no DEA registrant or there was no nurse on the other end of the phone, but it was a peer worker who had a phone who said, this patient's very high risk. Can you see him? So I'm able to take a history over FaceTime or the phone or a two-way platform like a doxy.me and establish the history of opioid use disorder and a very high overdose risk. I wasn't able to perform any toxicology at this time because they weren't allowing people to use the bathroom because of COVID risk. I was able to check the physician monitoring program online. He never had an issue, and I counseled him on how to do a home initiation of buprenorphine. I was able to prescribe him a week of a prescription and to a pharmacy 2 blocks away from the syringe service program and give him follow-up in a week. I had the PR give him naloxone and establish a safety plan about if he does overdose and risks of fentanyl, right? This patient was incarcerated for 2 years meaning he might not ever have really had exposure to fentanyl like a lot of the patients on the street might have right now. So he's very, very high risk of an overdose death if what he's buying could possibly, he thinks his heroin could possibly be fentanyl. And then there was the question of he doesn't have a phone. So in the era of telemedicine, how was I going to be able to continue our visits during this time? So again, trying to, leave it at that, but, trying to think about some of the ways that COVID-19 has changed the treatment of opioid use disorder, but some ongoing challenges. Thank you.
Thank you. These are very real issues that we all face today. And I think we're going to be able to spend some more time talking about this in the next part of our session. So thank you. Lauren?
Hello there. My name's Lauren Miller. I'm the Policy Section Chief at DEA Headquarters Diversion Control Division. And I appreciate the opportunity to talk with you all. If you want to do the first slide, please. Just to give you a short explanation of what we do, we enforce the Controlled Substances Act and its implementing regulations. And what Congress decided was setting up a closed system of distribution. And this slide points out that we oversee everybody who handles controlled substances from the point where it's first brought into the country or first manufactured through the distribution process to the practitioners, the hospital clinics, the opioid treatment programs to the patient, and actually even into disposal. So everywhere along that chain, there are DEA registrants. We have about 1.8 million DEA registrants that we oversee. Next slide, please. This slide shows some of the tools that we use. Basically, we have a variety of tools available to us to ensure accountability throughout that closed system of distribution. Obviously, we set up schedules and we have the registration process. We also have a system called ARCOS, which is automated reports and consolidated order systems that tracks purchasing from pharmacies, from distributors, manufacturers. We have security requirements that must be in place. We also go out and conduct scheduled investigations. So we go out to a lot of the 1.8 million registrants and we pay visits. We look at their record keeping, reporting, security, et cetera, to ensure everything's in place. So our primary focus here is accountability and ensuring that the system remains closed and that diversion does not take place. Towards that end, that's a challenging job because on top of trying to achieve this closed system of distribution, at the same time, we have the responsibility of ensuring that there's an adequate supply for the legitimate medical needs across the United States. And it's a balancing act. As you may have been aware, we've had to change some things with regards to quotas not too long ago, simply because we needed to maintain that balancing act and ensure there was appropriate supply coming into the country. That's pretty much all I have for right now.
Thank you, Lauren. That was very helpful and terrific insight. And now we'll move to Scott.
Hello, everyone, and thank you for inviting DEA on this call. My name is Scott Brinks. I'm the Section Chief of DEA's Regulatory Drafting and Policy Support Section in the Diversion Control Division. I'm a diversion investigator by trade. My section is responsible for all the regulations that are drafted by DEA. We are also responsible for the COVID-19 DEA website and the guidance documents on that site. Thank you for putting that slide up. The COVID-19 crisis came on quickly for DEA, and DEA immediately noticed the need for exceptions to regulations and guidance to the field. DEA immediately put together a small team of policy experts from the regulatory drafting section and Lauren's policy section to address these issues quickly in order to assure the adequate supply of controlled substances in the United States, continued patient care while still protecting against the diversion of controlled substances. One hurdle that DEA had to overcome during this crisis was the new Executive Order 13891, which became effective just last year on November 1st. Executive Order 13891 required that all guidance documents be approved by the Department of Justice and the Office of Management and Budget, which is the White House, before being released to the public. Prior to this executive order, DEA could produce and publish its own guidance documents without the extra approval steps. In normal times, this could add a significant amount of time to get a document published. Next slide, please. This slide provides a very brief timeline of DEA's response to the COVID-19 public health epidemic. In order for some of DEA regulations to be relaxed, there must be a triggering event, which in most cases is a declaration of a public health emergency by the Secretary of the Department of Health and Human Services. In the case of COVID-19, on January 27, 2019, the Secretary of Health and Human Services declared a public emergency. The public health emergency was very broad and did not meet the requirements to allow exceptions to DEA regulations and statutes, most importantly, the telemedicine. DEA immediately began working with HHS to establish the parameters of the public health emergency. The Department of Health and Human Services then added the necessary requirements to the emergency, which were that the public health emergency was a nationwide emergency and that it covered all controlled substances. Upon HHS issuing the further requirements, the public health emergency exception for telemedicine immediately went into effect. In order for DEA to make exceptions to regulations and issue further guidance, DEA needed to have requests from the public. On March 13, 2020, DEA received its first request from SAMHSA for an exemption to regulations. Even with the extra approval due to the new executive order, DEA had great support from the Department of Justice and White House. Between March 15 and 2020 and April 20 of 2020, that's a month and 5 days, DEA issued 24 emergency guidance documents to assist practitioners in the treatment of patients. Just for a reference, in 2019, DEA issued a total of 14 guidance documents. During that time, DEA also established a newly created COVID-19 webpage. Next slide, please. I'll give a brief overview of some of the DEA documents that were provided during the COVID-19. The first was DEA issued a guidance on telemedicine to assist doctors in better understanding how they could use telemedicine. Like take-home dispensing locations for those patients. DEA continues to monitor the progression of the COVID-19 public emergency, and we continually evaluate if further guidance or exceptions to regulations are needed. DEA 100% supports the need for the adequate supply of controlled substances and the most effective ways to treat these patients, but we still have to protect the public from the diversion of controlled substances. And that's all I have.
Thank you very much for that overview. Very important. Our next, Regina.
Thank you for having me here today. As Louis mentioned, I'm Regina LaBelle. I'm the director of the Addiction and Public Policy Initiative at Georgetown University Law Center's O'Neill Institute. I'm also going to head up a new master's program in addiction policy that we will, hopefully folks will hear more about in the coming months. We'll kick that off next year. So what we do at the O'Neill Institute is we work at the intersection of policy and law. And in our initiative, the purpose is to advance evidence-based practices to improve outcomes for people with substance use disorder. And the issue of medication-based treatment and access to the standard of care is a perfect example of the nexus between policy and law. So addiction treatment, particularly treatments involving controlled substances, such as methadone or buprenorphine, obviously, as we heard from the DEA folks, are highly regulated by the federal government as well as state governments. It's a complex web of regulations that interpret statutes or in some cases administrative practices. So DEA plays a very important role in regulation and oversight, but it's not the only agency that oversees medication-assisted treatment. Other entities, as was mentioned, is SAMHSA, also CMS through Medicaid and Medicare, and again, state governments. So state government role includes reimbursement rates, as does CMS, and state opioid treatment authorities. Some of the regulations have already been mentioned that have been revised in the past few months under the federal government's COVID-19 acts as well. So the state public health emergency authorities were involved as well. Revisions were made to telemedicine. There have also been revisions made to privacy laws under HIPAA to allow additional forms of telephonic communications. And additional flexibility in the amount of take-home medications of methadone, rather, that can be provided to individuals who may be early in their recovery. The American Society of Addiction Medicine has a great rundown of all of the changes that have been made that are available on the COVID-19 webpage. So a lot of the work that we do involves researching and writing about how past practices can influence future practices. And one thing that we know from research that was done after previous emergency situations such as Hurricane Katrina or Sandy is that there is an acute challenge to continuity of care, particularly for methadone treatment programs, which, as we mentioned, have a vast array of federal and state regulations. Now, some of these barriers are very specific to emergency situations, but some barriers exist all the time, even without an emergency situation. That includes transportation challenges and the requirement to go to a clinic every day that exists even in the absence of a public health emergency if you're early in your treatment, your methadone treatment. Last month, a survey of syringe services programs went out nationwide, and they found that 43% of the 173 syringe service programs surveyed had reduced services due to COVID-19. So the regulations that passed and the revisions to regulations have been very important, but we also can't forget about access to harm reduction services, which are important at this time for preventing, and every time, for preventing bloodborne disease as well as overdoses. We're tracking a lot of anecdotal information about overdose deaths and overdoses around the country. I think that there have been a lot of reports from upstate New York, a few from Ohio, Arkansas, Tennessee. It's important that we look further into those overdoses and overdose deaths and make sure we understand the circumstances that may have led to what we're seeing around the country, because we don't know that yet. But the time of Corona can really serve as a transformative time in addiction policy. When we look at the about 11% of people who need treatment for a substance use disorder receive it, about 30% of people with an opioid use disorder receive treatment. So maybe it's time to look at the laws and policies that could be barriers to expanded treatment access. Congress hasn't yet taken steps to make any of the revisions permanent, but there are people who will press Congress to either temporarily make these changes last for longer or consider making some of them permanent. Again, we really have anecdotal information from patients and treatment providers about how well the new rules are working, but this is an opportunity for natural pilots. There are some researchers that are looking at how COVID-19 is affecting delivery of treatment services in selected states. Others are examining the use of telehealth specifically. And then other research is being done to look at treatment quality and cost savings together under the new rules. So I want to leave with just two final considerations. First, HHS declared the public health emergency that allowed for some of these changes to be made. But the opioid epidemic was declared a public health emergency in 2017. And that remains a public health emergency today. So the COVID-19 public health emergency is not the sole avenue for these revisions. This is obviously a difficult time for everyone, as we should look for opportunities to expand access to treatment for those who are in treatment and remove unnecessary barriers, but also at the same time, make sure we're looking out for people who may not yet be in treatment, who still need services and care. Thank you very much. And over to Jeanne Marie.
Yeah, thank you, Regina. That was excellent. And let's go next to Jeanne Marie.
Hi, good afternoon, everyone. Thanks for having joining our panel. So I wanted to start with a case discussion that sort of mirrors what Dr. Suh presented. This was a patient who was struggling with a history of heroin use and felt sort of in the beginning of, as COVID was emerging, that he felt very isolated and wanted to get into treatment. He contacted our buprenorphine program, our certified recovery specialist, who contacted me about this patient. Ordinarily, her process would be to send the patient to our emergency department, where we have an emergency department buprenorphine bridge program, where we can start people on their first dose of buprenorphine and then bridge them to one of our outpatient clinicians. And then we follow them for the weeks and months of their recovery to sort of provide resources to help them sustain recovery. But this patient wasn't interested in going to the emergency department because he really feared the ED due to COVID-19. As I said, he was a little bit older. He also only had public transportation as a means of getting there, so he really wasn't comfortable getting on the subway to access a treatment program. And although he had a telephone, he didn't have a smartphone. So this was an additional barrier. He was presenting very early in the COVID crisis. And actually the first edicts from the DEA were a little bit hard to interpret whether or not telephone was okay or if it actually had to be a two-way video platform. Next slide, please. So the rapid implementation of a phone access program was what we decided we could move forward when the DEA came out with additional regulations that clarified that telephone, if necessary, was an adequate means of creating a patient relationship. So normally we have this peer-led model of recovery access. What we were able to do was to create a virtual clinic with several addiction medicine providers and ex-waiver clinicians to sort of follow these patients who get induced over the phone through a telephone program. And what we tried to provide was a service to the city of Philadelphia, allowing patients to access our virtual clinic while being engaged with providers over the phone. Of course, we have the same barriers. Some people still don't have a phone. We were also gearing up for thousands of returning citizens who are going to be released in a decarceration move because of COVID in some of the city and state jails. We were also trying to provide services to a large cohort of homeless patients who were being quarantined because of COVID-19 in an aggregate setting, but who weren't being offered substance use treatment at that time. And then we also had additional problems, which was while we could write longer prescriptions for patients who were already stabilized on buprenorphine so that they didn't have to keep coming back to the doctor, we had a lot of our primary care doctors who we normally hand off our patients to who couldn't see new patients in this time period because a lot of the primary care doctors were being deployed to inpatient programs in hospitals to battle COVID on the front line. So we felt that this phone access program could really provide a necessary service to a larger cohort of patients who were basically going to be put on hold during this COVID emergency. Next slide. So we found in the cohort of patients, a lot of our patients are doing incredibly well, perhaps better than some of them in the past. They're really, getting care in the privacy of their homes in a lot of cases. It is patient-centered. They're facing less stigma. We have some postpartum women who are doing great, and maybe that's because going to a clinic with a baby is a really hard time to seek addiction treatment because there's so much stigma that those young women face. So perhaps, some of these patients are doing better. There's no travel or exposure. There's no risk to the providers and no risk to the patients because of needing to get to a clinic. And because of all of these other, outside of the box thinking, I think some of the patients are really valuing more trust on the patient-provider relationship. Obviously, there are disadvantages because we're not seeing patients in person. Naloxone access is limited, so we can't hand them, a box of Narcan and make sure that their families know how to use it. There have been some, ingenious methods of getting naloxone to people through the mail and through the limited syringe services that are open right now. One of the other problems we found is that, in order to access telehealth, you have to be a patient in a health system. Telehealth is not easily accessed by people who don't already have records and a provider. And most of our patients don't have primary care providers and don't have, pre-existing telehealth access. In addition, the disadvantages of perhaps some people have a therapeutic experience around urine drug screening. Some people think that structure is good for patients. Other people think that this is one of the advantages of, not having urine drug screening access at this time. So could really be a benefit or a disadvantage. And then the diversion risk, which may or may not be greater or lesser depending on how closely you're following patients and what your level of assessment is of their sustained recovery. But I think these are all important topics to consider when we think about expanding telehealth going into the post-emergency period.
Terrific, thank you. Well, I think all of you presented some terrific information and some insights on the work that you do and the things that you think about. When we put this together, we thought we'd try to ask some very specific questions that I think a lot of the people that are viewing the webinar would really like to have some of the answers to. So what I'm going to do is go through a series of questions. The questions are going to be written out so people can read them, and I'll try to be brief as I read them for those who don't have the ability to see their screen. And if we can just give hopefully a fairly direct and focused answer. If anybody else on the panel feels that they'd like to comment, I would certainly welcome that, but I'd like to keep the session, the next few questions, down to about 15 minutes or less if we can. So let's try to keep it as pithy as we possibly can, without trying to overly limit everybody. So I think Dr. Suh, this is a question really for you. What intervention and harm reduction strategies should cities and states be considering or ramping up to reduce the risk of transmission of COVID among these groups?
Thank you so much. Yes. I spend a lot of time thinking about this, and it's been very interesting. As Regina said, we also have almost these like natural, pilot programs happening around this, the country, where cities and states are taking different approaches to all substances, not just opioid use disorder, but also alcohol. There have been a lot of debates about access to alcohol, and especially as we're thinking about healthcare capacity, we're all wondering, where are the patients with alcohol withdrawal in the emergency room? I think knowing the statistic that so many of the places that people have normally been going to that are physical locations where people can access harm reduction services, including, syringe service programs where I see patients. Those are places where people can get access to sterile syringes. They can get access to, a whole variety of things, naloxone, sterile syringes, cookers, anything else that people might need, sterile water to use substances more safely. We've really been concerned that people are increasing sharing syringes, they're reusing syringes. These are things that when we think about the HIV outbreak, for example, that happened in Indiana in 2014, thinking about how we already have places that have very little access, trying to think creatively about access to what people need to use more safely and to prevent transmission of infectious disease. So again, thinking about access to those maybe through the mail. We know that some cities have been doing methadone delivery in cars. We know that places where people are quarantining in hotels, we're putting access to services in San Francisco, putting naloxone in the lobby for people if there's an overdose, or putting having those services available also where people can dispose of syringes safely, having them be as close as possible to where people are living and using. And then even thinking about access to substances, that different public health departments have been thinking about access to alcohol, and access to medications such as buprenorphine and methadone to keep people out of the worst stages of withdrawal, which for benzodiazepines and alcohol could sometimes be fatal. So I think thinking broadly about some of those things is important. Thanks.
Thank you. Anybody else? Good. Well, that was great insight. Thank you. Regina, policies like social distancing and avoiding non-emergency medical visits, while obviously necessary to help flatten the curve, may increase the risk for occurrence of use for patients in recovery because they increase social isolation and limited in-person social support. What are the potential long-term implications of these policies with substance use disorder? And kind of as a corollary, what data do we need to evaluate the risk and benefit of these practices?
Thanks. So I think there are two. I'm going to distinguish between supporting people in recovery and telemedicine for addiction treatment, long-term ongoing recovery, to distinguish that from short-term treatment. So research has shown that treatment via telemedicine actually is effective at retaining people in treatment, and as well as long-term outcomes, improve mental and physical health and well-being. So we know that telemedicine actually does work. I think that telemedicine treatment is going to be, I believe that's something that Congress will become even more interested in. They did include telemedicine provision in the Support Act that from a couple of years ago. So I think that is here to stay and will be expanded. I think Dr. Perrone raises a really important question about the issue of having a primary care provider. That's something that has to be looked at. As far as recovery supports, there isn't as much research on that, and that's where the social isolation comes in. That's where a lot of people are talking about, particularly for people who may not have access to a computer, and they really rely on those meetings. And that's something that's been brought up quite a bit, the importance of the in-person meetings. So we don't know as much about the long-term implications of that. So we have to make sure that we're allowing for providing for that recovery support programs through public health systems. What should we be looking for to evaluate the risk and benefit? Certainly for telemedicine, it's all the traditional outcome measures for treatment. For recovery supports, how do we evaluate it? I think we evaluate some of that by asking the people who are in recovery, the people with lived experience, what is your experience? And talking to them about what would make it better for them. Really asking that question of people with lived experience so that we can better inform our long-term policies.
Perfect. Thank you. Any other comments from any of the panelists?
I mean, I definitely echo the voice of the person in recovery. I think that's been an important part of our program, and I'm glad you acknowledged that. I think there has been a tremendous opportunity to go virtual in recovery meetings that's been very successful for a lot of people, but then again highlights that digital divide and other social determinants of health for the large number of people who may not have access to the video aspects of it, or a formal computer or a phone with smartphone access. So while I think some people are doing pretty well in recovery accessing virtual platforms, that still is not available for everyone.
Good. Well, thank you. Any other comments? While we have you, let me ask you this question. Do these solutions have the potential to transform how we deliver addiction medicine in the future? And if so, how?
If that's me, I definitely think this is, the most patient-centered thing that has happened to addiction medicine in the past probably years or forever. I think probably many of us have accessed telehealth in the past couple months for the first time ever. So it's really undergoing a telehealth revolution. But I think this is one aspect of care that really fits into the privacy of someone's home because of the stigma that we're still trying to tackle and some of the other logistical barriers. I think it really gives us an opportunity to provide a patient-centered answer to a lot of addiction care. As we know, for primary care doctors and office-based opioid treatment, buprenorphine should be part of primary care. It should be part of a telehealth platform in a primary care doctor's office, but there's still so many barriers to clinicians thinking of buprenorphine as part of primary care. So a recent study came out looking at a third of primary care doctors didn't believe in or support buprenorphine in PCP practice. So I think that's some of the barriers that we can overcome by expanding telehealth and getting the providers who are able to care for this patient population do so in a more efficient and patient-centered manner.
Can I say something as well? Prior to COVID, I spent a lot of time thinking about, for example, in the state that I live in, New York State, this problem of the mismatch between patients that need access to opioid use disorder treatment with medication and kind of where people were located. There was thinking about pre-COVID and thinking, wow, there's a lot of patients in rural parts of New York that don't have any buprenorphine providers. How can we deal with that? We did know that there was a requirement for, an in-person face-to-face for initial patients, that has been waived kind of during COVID. You can think about the mismatch across states, and you can think about the ways in which we have big gaps where there are a lot of people who are able to provide this care or interested in doing this care rather, and places where there's kind of treatment deserts. And so thinking about novel ways that we can think about delivering that care that really is evidence-based, that's safe, that gets both methadone and buprenorphine into the hands of people really at the moment that they need it, really being so flexible to get people what they need. When someone experiences an overdose and then gets discharged from an emergency room without access to medication, we know that's a missed opportunity. How can we lower the barrier when people have kind of that area, that time of interest, the time of engagement, and we can meet people where they're at? How can we think about minimizing the number of times people have to go out, whether it's to a methadone clinic? If they could pick it up from a pharmacy, that would be really amazing, as one of the panelists said, which is a barrier for patients with OUD, not for chronic pain. But thinking about ways in which we can really get these medications that are the most effective evidence-based thing into the hands of people who need it in novel ways.
Well, to address that, actually, maybe I could ask Scott. There have been a lot of questions in the chat already about this specific issue, and I think that the two prior panelists actually asked the same questions about what's going to happen to the new state of regulatory affairs once the pandemic has been declared to be over. So maybe you want to address those issues from the DA's perspective.
Yeah, I've been reading the questions too as we've been going. I see a lot of questions about that. One person asked about the Ryan Haight Act. Well, right now, once the declared public health emergency expires, all these exceptions to regulations and guidance documents that DEA issued, they will expire when the public health emergency expires. Telemedicine will also return to how it was before the COVID-19 public health emergency. Telemedicine regulations, or the Ryan Haight Act, they're law, they're in statute, and they can only be changed by Congress. DEA does not have the ability to change those. But one thing I have noticed in my experience as an investigator and in this section is that there's a misunderstanding of what telemedicine really means when it comes to prescribing controlled substances. I'm going to leave that to Lauren, though, to explain that.
You want to let Lauren explain that right now?
Sure.
It is actually the next question I had for him. So maybe I can address that right now, Lauren.
Certainly. The Ryan Haight Act basically addressed a problem that we had in the country, which was that there were a number of people across the country who were overdosing and dying with controlled substances they had obtained where there was never an actual relationship between the prescriber and the patient. And as a result of the Ryan Haight Act, one of the requirements that became or that was clarified was that a prescription to be issued for a legitimate medical purpose in the usual course of professional practice had to include such things as a physical examination by the prescriber of the patient. So they had to be in the same room, evaluated by the prescriber. And this literally shut the door on the internet diversion of controlled substances almost overnight. it shut down a lot of pill mills that were pumping out drugs across the country. The requirement of that in-person medical evaluation, though, did have a feature in the Ryan-Haight Act that made things a little bit easier if you couldn't do the in-person, and that was telemedicine. If a practitioner can't conduct an in-person medical evaluation before they need to issue a controlled substance prescription to the patient, then they can establish a doctor-patient relationship through the use of telemedicine. But telemedicine requires that it can only take place if one of 7 exceptions are met. And the first 2 of those 7 exceptions are by far and away the most common prior to COVID-19. The first one being that the patient had to be in a DEA-registered hospital when the communication was taking place between the prescriber and the patient. Or the second was that the patient had to be in the presence of a DEA-registered practitioner when the communication was taking place between the prescriber and the patient. Now, that practitioner could be a mid-level practitioner. The point or the misconception, though, that exists, and we continue to battle this misconception, is that you have to have a physical examination before you do telemedicine. That's not the case. Telemedicine exists when you cannot conduct that in-person medical evaluation. Then you can, if you meet one of the 7 criteria, then you can do telemedicine. We routinely get questions about practitioners asking if how often they must see a patient by telemedicine, how often they must physically see a patient if they're going to continue telemedicine. Once that physical exam takes place between the prescriber and the patient, telemedicine ceases to exist. That's the point at which the practitioner and the patient can communicate orally in any way, shape, or form they wish. It's so long as you're compliant with any state laws or regulations. But if you need to do that in-person medical evaluation, then do so. But once that takes place, telemedicine ceases to exist. And that's become quite a frustrating point, because there are practitioners who are telling patients that they must come back each time to do telemedicine and be physically examined. That's not the case on the federal level. Now, in talking about the use of telemedicine for treatment, the fact is that we have never been a barrier to prescribing buprenorphine and other FDA-approved Schedule 3 through 5 narcotics for the treatment of opioid addiction. Telemedicine can be used for that platform, and buprenorphine products, and have been for some time. There's another misconception that for some reason our regulations prohibit that. They don't. So I hope that answers your question appropriately.
I think it's a good answer. I'll go on, if we can, to the Q&A session and just follow that comment with a question that I think has been asked several times in the various chat boxes. But what are people doing, and what should they be doing for medication monitoring, specifically about urine drug screens for patients who are now being managed through a telehealth platform? And any panelist that would like to answer it can. We'll keep the answers brief, hopefully. Are there any expectations from the DEA? Are there any in the practices the doctors are having? Any policy implications that you can think about on the legal side?
I think I could just make a quick comment. I think, urine drug screening can be therapeutic, or it can be more, I won't say antagonistic, but controversial, at least. But I think if you're going to take an action, just like we teach people with, urine drug screening in the setting of overdose, if a patient, admits to, having a slip or having a tough week, is there a role for urine drug screening, or is there a role for, just sort of immediate counseling and bringing the patient to a higher level of care and more frequent visits. So unless you're really going to change something substantially, I don't think there's a role for routine urine drug screening in a patient relationship that's ongoing and that's achieving some of the goals of the patient's recovery.
Other thoughts?
The DEA has no requirements concerning urinalysis or drug testing.
It's definitely, okay.
Oh, I just agree with Dr. Perrone that, like any test that we order, we want to make sure that it informs or changes management. We also know that, it's really hard even for when we pull people in medical school and physicians, people really inaccurately understand and interpret urine toxicology generally. So again, does it change our management? And I think, really telemedicine has allowed me to have some very intimate conversations with people in their own homes about substance use, and talking to people, you can get quite a robust history of what they're using and what difficulties they're having without doing toxicology, and helping people through that with all the skills we have, motivational interviewing, checking in more regularly with people, with recovery coaches, really that we have so many tools we can draw on now, and really to help people who might be having trouble with multiple substances.
Good, yeah. As Dr. Perrone commented, it is a very controversial topic, and I think many people feel it provides a lot of structure for people. Whether or not it does is something that is very much a perspective that everybody, has based on their own clinical practices and philosophies. But certainly, your points both are quite excellent. Any other comments about that?
Just briefly, I think the clinical aspect of urine drug screening and how you interact with your patient is one, but urine drug screening is also used often in non-clinical settings such as drug courts and other criminal justice involved, child welfare, et cetera. So that is a host of other policy issues where there actually does need to be more training about how to use it most effectively as a motivation, and when to use it and how, and is it overused, which is often the case in non-clinical settings.
Good, thank you. Since you mentioned drug court, it's something we haven't really said much about. I just wondered what your thoughts were about drug court, particularly in the COVID era, both in terms of how COVID will impact the ability to have those sessions, and whether there's any messaging that has to be done to improve people's willingness to participate in both drug court and even coming to the emergency department or recovery clinic in the age of COVID.
Yeah, I think so there's judicial emergencies in every state, as well as public health emergencies. And so courts, just like any other, drug courts, just as any other court, have to practice social distancing. The majority of them have established programs where they can check in. So not telemedicine, but, telelaw, I guess, where they're checking in on participants. And I know that the National Association of Drug Court Professionals and the Center for State Courts is doing a great deal of work to try to help drug courts and other judicial systems make sure that they're able to provide the access to the type of care that their clients, that their participants need. And it's been, quite a challenge for them as well.
So there's a series of questions that could probably be tied together with the safety of some of the burgeoning practices that we now use for implementing sustaining recovery, such as the use of recovery coaches or peer navigators, and how that's been impacted by COVID, whether we can sort of message that out as a safe practice. And the corollary to that, a few questions have come up about safe consumption facilities and whether or not those are likely to wither on the vine, or something that we could actually improve and make more robust, given the risks that people face and the concerns people face with COVID?
I can answer a little bit. I think, peers and syringe programs, they would be out there if they had appropriate PPE. They are an earnest and committed group that I think are suffering from, a lack of protective equipment to feel like their employees and volunteers can be safely protected. I think as the prevalence of COVID goes down in certain areas, there will be loosened restrictions on other types of essential workers that will allow people to get back up and running in those programs. But in my view, they are essential to the safety of a large group of our patients. And while they have been successful working remotely, we do have iPads on wheels, and they can provide consultations in our emergency department. I think their preference is to really be out on the streets, handing out Narcan and trying to access people and get them back into care. So there's a lot of different roles for peers, but I view them as essential workers. And if we had enough protective equipment for all the people who need to be out in the community, I think we would have a bigger army to help our patients at this time.
Yeah, weighing in on the question about using alone. So we know that many places around this country that, even when people get housed, that it's a risk for people to die of overdoses once people move from, congregate shelters into places where, they might have their own housing. We know that isolation and using alone is a huge kind of public health question. The question of safe consumption spaces remains essential. When I think about my patients, the ones that are the most engaged, are the ones that don't show up, are the ones I'm worried about, who might have used in an alley or used in a bathroom. And so there's all kinds of technology coming on board. There's some never use alone hotlines and apps that people have been developing for a while now that I think are really important during this time of COVID. But also thinking that there are a lot of people who use together, and we've always had people keep each other, eyes on each other, to give naloxone and to call 911 to help each other out. And I think that mutual aid and that help from people who use drugs on each other, as well as peers and other people, is really going to be critical. It was critical before COVID, and it's critical. It remains critical now. So having sterile places where people could use and could get naloxone, which could prevent anoxic brain injury, respiratory depression, and death, that critical time period is always what we try to think about.
Thank you. I'd like to ask one final question I think the DEA might be able to address, and then I'm going to ask one final question for the group, and we might run 1 or 2 minutes over, but we'll try to keep it brief. So there were a string of questions about things like decentralizing methadone. I know that's not specifically DEA issue, but sort of a perspective on whether the current oversight process that we have is the best we can do. And sort of a related string that does show up in a few places is this idea of using buprenorphine diversion as a harm reduction strategy. I know that's not something you can publicly advocate, but these are things that are being talked about as important processes to put in place to sort of reduce the risk that people have from the use of opioids. Any thoughts?
I think I'd really need to know more the type of question you're asking, or some of the questions you're encountering.
Yeah, I mean, the question really is right now, in order to get people to get methadone, obviously you have to go to a methadone treatment program. You can't go to a pharmacy and get it. And obviously access from, Manhattan is probably not very difficult, but from rural America might be very hard. So by decentralizing that process and allowing people to get it from the pharmacy, for example, or from a standard recovery program, might make getting it easier. That's exactly what happens with buprenorphine, of course, where you can get it from a pharmacy. But one of the issues a lot of people have raised with buprenorphine and liberalizing its use is that it's actually being put forth almost as a as a diversion, as a harm reduction strategy. In other words, we have a lot of it out there, so it's going to reduce people's likelihood of overdosing because they now have buprenorphine available to them. So those two seem to sort of be working in opposite directions in a way.
Please keep in mind that the methadone can't be prescribed so for the treatment of opioid use disorder. So utilizing a pharmacy for providing treatment takes away a couple things. First off, you don't have the community that was talked about with opioid treatment programs, but also you don't have the capability to prescribe methadone for dispensing from the pharmacy setting. There were a couple of opioid treatment programs that were pharmacy co-located. However, I'm not sure that they even exist anymore. It just didn't seem to be a successful effort. If you're talking about buprenorphine being a good harm reduction tool, that's a medical decision, not a DEA decision. That's something that has to be based on good, solid science. And there's not much that we can address with that regard. We're dealing with enforcement of the laws and the regulations as they exist.
Fair enough. Any other comments?
I mean, the laws around methadone didn't have a lot of evidence basis in the beginning, much like the X waiver, requirement for clinicians to, have a 8-hour training program in order to prescribe buprenorphine. So I think those are good things that we can go back and when we look for evidence for why we should, continue telehealth or look at other policies, I think that's one that isn't based in a lot of evidence and is one that we should really reevaluate going forward.
Yeah, and just speaking to the question of, access to methadone and buprenorphine as harm reduction strategies, it's just good medicine. Let's just be clear. What is good medicine is really, we know that the strongest thing that protects people from overdose and non-fatal and fatal overdose is timely access to medication for opioid use disorder that treats their cravings and that that can keep them safe. So thinking just about the sheer number of people that we've talked about on this panel who have opioid use disorder in this country and lack access to those medications, really thinking about all of the different strategies that we've discussed have been really wonderful, and thinking about ways that we can take a close look at why these medications have been so bound up here in the United States, and thinking about comparing it to other countries, thinking about why is what happened to why is methadone prescribed the way it is for opioid use disorder and for pain in this way. And we have very safe and effective medications that for this disorder, and we need to figure out the public health problem of getting it into people's hands at those moments when they need it, and also harm reduction strategies and supplies when they're not able to access that, and making sure that people have access to both, as well as recovery supports for early and long-term recovery.
Thank you. So before we finish, I just want to ask everybody if they would give a 20-second or less answer to this question. What is the single most important policy or practice you would implement to meet the needs of people with opioid use disorders during this pandemic? And we can start with you, Kim.
It's hard to think about one, but it would be great to have some legislation where we could remove the waiver on prescribing buprenorphine. I think, like any other medication, doctors should be able to in the setting of an opioid overdose crisis in the country.
Thank you. Lauren?
Well, from DEA's standpoint, the only thing I would say is basically we depend on the science. The research that comes out of this public health epidemic will be very interesting to find out its impact on treatment and how successful it was or wasn't. So we're looking forward to the science.
Thank you. That's excellent. Scott?
I would agree with Lauren. I think it's too soon for me to decide that. We have to wait to see what happens in the future with the science, the statistics, the investigations out in the field to determine what worked and what didn't work.
Okay, that's a very fair answer. Regina?
Well, I was going to say get rid of the X waiver, but that was taken. So I'm going to say having an emergency, we've given emergency funds to the states to deal with COVID and substance use disorders. I would do an emergency through CDC to fund syringe services programs, because I'm very, very concerned, given the economic downturn we're going to face, that local governments are not going to be able to fund these in the future, and that will hurt us not only on opioids but also on HIV and Hep C. Thanks.
Thank you. And Jeanne Marie, final word?
I do think that, incentivizing health systems and reimbursement around substance use disorder treatment so that these patients are not so disenfranchised would also help. Of course, I would say X the X waiver, but other opportunities to improve care exist as well.
Terrific. Well, listen, I want to say thank you to each and every one of you for a quite robust and enlightening discussion about a really challenging topic, but something that's so critical today, even more than ever. So Scott, Regina, Lauren, Jeanne Marie, and Kimberly, thank you very much. And I'm sorry we didn't get to all the questions. There are literally hundreds of them in the queue, but hopefully we'll be able to address them in a little online FAQ. Thanks again to ACMT for organizing this and for Paul and Adrian for really pulling the strings behind the scene. Thank you again.
Thank you.